My name is Ntlamo Lonkanyani. I'm the Senior Manager Professional Conduct. Thank you. So the overview will be the introduction, the legislative background, the general regulation in terms of the Medicines Act, the Section 22A of the Medicines Act, Section 56(6) of the Nursing Act, PCDT supplementary training, and professional conduct matters. Thank you. If I'm fast, you'll notify me. So the introduction goes like this. Council is established in terms of Section 2 of the Pharmacy Act. The objectives of council are found in Section 3 of the Act. So the main objective of council will be to regulate pharmacists and pharmacy support personnel. And one of the ways of regulating pharmacists and pharmacy support personnel is by regulating the manner in which medication may be dispensed to patients. So the pharmacist and the pharmacy support personnel are required to comply with the phases of dispensing prescribed in Rule 2.7 and to make sure, where necessary, that the medication dispensed, it is based on a valid prescription. So the phases of dispensing will direct you in terms of the scope of practice, the legislative background as displayed or flighted on the screen. You'll see that in terms of Rule 2.7 of the rules relating to good pharmacy practice, we have 3 phases of dispensing. So the 3 phases of dispensing may be performed by a pharmacist or a pharmacist intern under the direct supervision of a pharmacist. So those 3 phases, they may be performed by a pharmacist or a pharmacist intern under the direct personal supervision of a pharmacist. So when a pharmacist intern dispenses that prescription, he or she must be under the direct supervision of a pharmacist. Phase 2 and 3 may be performed by pharmacist assistant and in brackets, post-basic, also under the direct personal supervision of a pharmacist. So in terms of phase 1, it's where now the pharmacist will interpret and evaluate the prescription. Rule 2.7.1.a.I, the pharmacist must ensure the legality and the authenticity of the prescription. This is also supported by Regulation 33(4) of the regulations of the general regulation published under the Medicines and Related Substances Act. So slide 3 is just the highlight of the entire regulation, but we have some of the issues that we have highlighted in bold. So subsection 1 of Regulation 33 says that a prescription must be dispensed. Every prescription from a medicine shall be written in legible print. Hence, we have highlighted legible. It is one of the most important part of the legislation. It may be hand or typewritten. So under the typewritten, also we have highlighted in C that if that prescription is prepared in an electronic agent, it must be in compliance with the ECTA Act of 25 of 2002. Sub-regulation 2 says a prescription shall be signed in person. That means if it is signed in person, it will be a handwritten prescription. And then B says in case of a prescription prepared in accordance with sub-regulation 1C, an advanced electronic signature as per section 13 of the ACTA Act 25 of 2002. And it must be done by an authorized prescriber. So we have also...
Maybe just before you move, Z, let's go back to that slide. I think this is where the emphasis comes in from our side in terms of the current languages. When we refer to the prescription shall be signed in person, there we refer to an ink. It must be in an ink. And then when we go to B, that's where we refer to as wet signature. So for all of us, I'm sure with COVID, you would have seen many of those wet prescriptions. I think that's the terminology that's being used in the market, or digital prescription. And I think it's very important that we distinguish between a digital prescription and a handwritten. So you can type a prescription, but still sign in person using an ink, or you can type it, then put in an electronic signature, which is in compliance with the ECTA Act. And in this instance, we are not asking for somebody to sign their signature, take an image and input it on a prescription. That does not comply with 2B. The 2B is specific to make sure that the signature must be encrypted so that nobody can copy it. So I think it's very important that we clarify that, because we previously saw prescriptions where somebody just take an image of their signature, append it to a typewritten, and they think it is legal. It's not in compliance. So if you type right and then you can then sign in person using ink, then that makes it legal. If you want to go full electronic, please make sure that we use the encrypted signature. That is like.
Thank you, Mr. Tala. Can we continue, Z? So in terms of sub-regulation 3, those are the details that must be contained in the prescription. I won't state each by bullet form, but they say that the prescription shall at least state the following: the name, qualification, registration number, with relevant statutory number. Maybe what we can look at, you can go down, Z. I think there is a point where they say that an identification number, maybe it might be an issue of contention. Also, the address, it might be an issue of contention in terms of OP. So it is up to the prescriber or the patient. I don't know whether there will be a consent, but in terms of OP, you'll know that in certain circumstances, consent is not required. Thank you, Z. These are further requirements that are required in terms of Regulation 33. You can go down, see. I don't think we can deal with this one by one. In terms of regulation, sub-regulation 5, in the event of the prescription being transmitted electronically by means of other than an electronic agent, in terms of sub-regulation 1, by fax or communicated verbally, a permanent prescription shall be made for record purposes. So this one is also supported by section 22A56 to say a verbal prescription shall be followed by a signed prescription as per sub-regulation 2 within 7 days, 7 working days. So there was a question in terms of to say if a prescription is an electronic prescription, it must also be followed by an original prescription. So the answer is no. If that prescription, it was done electronically, the regulations allowed for an electronic prescription. Thank you, Zé. I think my colleague will take over from here. Thank you.
Thank you, Mr. Nkanyana. I hope the colleagues can see me. Good evening. My name is Yanda Mfuko, as I was introduced. I think we will just briefly touch on the issue of who is an authorized prescriber. A few slides back, it talked to a prescription of an authorized prescriber signed by the authorized prescriber. And the Medicines Act does define an authorized prescriber as any person authorized by the Act to prescribe any medicine. It's very, very broad. However, when you then go to Section 22A of the Medicines Act itself, together with the published updated schedules, you would see that the Medicines Act starts narrowing it down on showing us as healthcare professionals on who may prescribe what is the limitation based on the scope of practice of that registered person, and also that limitation being subject to the indication of the use of the medicine that is being issued. We also see a limitation of prescribing in terms of Section 56.6 of the Nursing Act, and what we call a PCDT pharmacist primary care drug therapy. And so I've just done a summary of the different schedules on who may, well, the Medicine Act defines it as sell or states it as sell. We all know that scheduled not substances and unscheduled can be sold in an open shop. Those are the ones that they don't need a pharmacist nor the prescribed authorized prescriber doesn't need to write a prescription basically. And your Schedule 1 and Schedule 2, therefore, according to these points, may sell and therefore may give to a patient, which is your medical practitioner, dentist, vet, pharmacist-initiated therapy by the pharmacist, and you will have a practitioner and a nurse. In the next slide, we will talk on who this practitioner is. Schedule 3 and up to Schedule 6, it is those three that may sell or prescribe to a patient based on their scope of practice. That's number one. And the pharmacist may sell this item on a prescription of an authorized prescriber, right? So that is just the summary of Section 22A. Further to that, SAPRA then published the schedules. And in the schedules, SAPRA states clearly who the practitioner is, because it talks about the pharmacist, but it also talks about a practitioner, a nurse, or a person registered under the Health Professions Act, the medical practitioner, and a dentist. And who is this practitioner? There's people, cadres are listed as paramedics, emergency care practitioners, ambulance assistants, and emergency assistants, etc., right up to optometrists and podiatrists. So each schedule, if we can go into those schedules very specifically, it would tell you what is the limitation of who may prescribe what or issue to a patient on which grounds based on their scope of practice as they are registered. Then to briefly touch on the nurse, the Section 56.6 of the Nursing Act states to us that despite the provisions now of the Medicines Act, the nurse who is in the service of the national department, provincial department, or municipality, we would want to call those in the public service, so they would be in our various public hospitals, etc. Or D, being very important, an organization performing any health service that is designated by the Director General of Health after consulting with the Pharmacy Council. This person or these people as defined here are nurses and authorized by the DG and the head of such provincial department, etc. They may, number one, do a physical exam on any person, diagnose any physical defect, and number three, keep prescribed medicine to supply them, that's number one, administer or prescribe on prescribed conditions. So 56.6 is not a blanket approval. There is conditions on which such designation may happen. So our public facilities have, in fact, a Section 56.6 designation by the minister, and therefore the nurses that are there would be able in the clinics to perform all this, which is why they may prescribe. And someone would ask, what then happens if I'm in a private setting? This is where 56.6D applies, where you would apply to the DG for such designation, and should the DG issue that nurse with the Section 56.6 designation for the services that they would be performing in that community, there would be conditions that are stipulated in that 56.6 designation. And that is the only time where a nurse may prescribe. Otherwise, the nurse may keep their stock, supply it, administer it to the patient that they are seeing. And to continue on section 56.6, it then says, it is to be noted that the nurses may then only prescribe medicines for adults and children according to STGs and EML. It is important for the pharmacist to therefore validate the designation of the nurse in order to ensure that the prescription in terms of Regulation 33 of the Medicines Act is kept, and then the pharmacist may dispense such prescription. Outside of the 56.6 designation, the pharmacist may not dispense that prescription. This talks to the nurses. And then we come to the primary care drug therapy supplementary training. In terms of the regulations relating to supplementary training, as published in terms of the Pharmacy Act and the provisions of control of such training, and I pulled only just one part, that the training of the PCDT is in terms of those regulations. So it is regulated that you may have a PCDT supplementary training that is done, and such permit holder may diagnose, prescribe, administer Schedule 1 to 4 medicines for conditions that are listed in the permit. The permit comes with the listed conditions, and it is according to the PHC, STG, and EML. It cannot be outside of that. It is the limitation. This includes the Schedule 1 and 2 medicines, but those already would fall under the scope of a pharmacist as pharmacist-initiated therapy. I think I touched on it beforehand. So it is important to note that the PCDT pharmacist would have obtained the necessary training, would apply to the DG for a permit, and the DG would give the permit. The permit will have conditions and a list attached for the conditions that the pharmacist may diagnose, may prescribe for, and administer such medicines, and not beyond that. And now I hand over again to Mr. Nganyane to just take us over some issues of professional conduct that we pick up as Pharmacy Council. Thank you.
Thank you, Z. Thank you, colleagues. The common errors that we normally find at professional conduct, it is in terms of eligibility of handwritten prescriptions, which increase the medication errors. For example, in most of the cases that we have had at our committees, the cytotech and cytologist, we are having a high number of those dispensing errors. And in most cases, if you can ask your colleagues, these matters, they get referred to the Committee of Formal Inquiry because of the seriousness of the complaint. So we urge our doctors who are attending here, maybe to try to be on a slow motion when they are writing out prescriptions to patients, and this prescription will be taken to the pharmacist to be dispensed there. So another one that we have is the dispensing shortcomings. This will mostly happen in a chain pharmacy where a patient will go to a pharmacy, and that prescription will be captured at a pharmacy, and the first repeat of that prescription will be dispensed at that a pharmacy. But when now the patient moves to Giyani, to the second chain pharmacy, which will be B pharmacy, the B pharmacy will only have a profile of the patient and what previously. And the problem will be now where if the prescription was incorrect, so the patient will continue to receive wrong medication or the dispensing error will continue. That maybe if the patient is admitted, then they'll have to check, but we always advise pharmacists to rely on the Section 22A and the regulations in terms of contacting the authorized prescriber to authenticate or to check what kind of medication is prescribed if they cannot see the what is written in the prescription. But that we know that it takes a lot of time. Sometimes they are in respect of the doctor is online, she's not with that doctor, and they are patients in the prescription, and the patient they'll be screaming at to say we've been waiting in the line, you're not assisting, but the issue is that we have there, it's not legible enough writing out a prescription. Then we also have the electronic prescriptions, as you could have seen in the regulation 33. So my understanding is that clinic will are encouraged to reduce the medication errors, because if it is typed normally in Word, Word will correct you to say the spelling is not correct. Then you'll have to type the correct name of the medication. So the prescription has the same legal force like the 10 prescription that is containing regulation 2, 1 and 2, B and C. You can go down and see. Thank you.
That thing, I know you keep disappearing, and I think it might be
TA Act. It says it defines what is an electronic signature. Yes, it might be the load shedding. Can you hear me now, colleagues?
Yes, we can hear you, but you keep on disappearing. But continue. Thank you.
Thank you very much, colleagues. You will have to stop me if I disappear. The ECTA Act provides for an electronic signature. So there are two differences between an electronic signature and
Yeah, no, we've lost you, Mr. Nkanyane. And maybe Z can continue. I'm not sure, just to assist. Thank you.
Yes, I'll take over. Apologies for that, colleagues. He is attempting to speak. Sorry about that. And so the issue of the electronic signature as we continue is that a signature being required to safeguard the authenticity and providing proof of the actual person who has signed. And so it is important that we, in line with the ECTA, we then provide the electronic signatures. I think that Detlala also highlighted on it, on the encryption of such a signature, not just a picture photograph of copying from pictures and then signing a prescription, just to ensure that the person who has signed is actually the one who was either writing out the prescription or the actual prescriber at that point in time. And so it is a distinct way of identifying a person, and each person sometimes has a short and a long signature. It's in the next slide, but I think I'll say it here, that this is where it's also important, perhaps in a setup of a hospital, let's just say a hospital setting, where the pharmacy must know the signatures of their regular practitioners that are coming into the hospital, short and long signature in order to authenticate. Those are some of the ideas, or even any other system that a pharmacist may put in place in authenticating such. We know that in the news not so long ago, there were claims or allegations that there's bogus doctors. I believe that the practitioners that are there, or the medical practitioners, etc., and as registered with various councils, that they are not bogus, they are there, but there's people that would want to pose themselves as doctors, as pharmacists, as nurses. Meanwhile, they have not been adequately trained to do so. And therefore, in the healthcare professional ensuring that the signature is encrypted, that it is their own signature and in line with the relevant legislation, that they are ensuring that they are prescriptions are authentic and they are valid, and the pharmacist is able to authenticate that. I must also just add that the Medicines Act also does say that, for an example, if it's a telephonic prescription or faxed, it must be from a prescriber known by the pharmacist. This is to prevent such things, because if it would come from one that a practitioner that's unknown, you may be unable to trace such a prescription. And therefore, some of the things we have touched on as we went along, but I've also mentioned this first point of perhaps having in a hospital setting the list of authorized prescribers, short and long signatures there. And just, I think it was yesterday, where we also found that a patient had phoned, actually a pharmacist phoned into the office to say the prescriber had forgotten to write a date. And when the pharmacist asked for the date, the patient took the pen from the pharmacist and started writing the date on the prescription. I will pose that question to ourselves: is that legal or not legal? The issue of legible prescriptions, I think Mr. Nganyane touched on it. And also, I think as we work together in the same communities, in the same hospital, as we see the prescriptions wherever that we are, I think the communication, these days we call it collaborative practice. It doesn't necessarily mean that we work together under the same roof, but the communication between healthcare professionals builds that relationship, that we know that indeed Dr. Mawela did write that prescription, and yeah, it looks strange that Dr. Mawela could write this, a prescription looking like this, and therefore be able to call and we talk about the prescription and assist the patient as such. And as I draw to a close, Pharmacy Council wouldn't keep quiet in this time to shout out for Pharmacy Month with the topic that we have there, that pharmacy is safe and a trusted place for advice and assistance. And therefore we do encourage our pharmacy professionals that are here to work with all healthcare professionals in order to ensure that we highlight the matters of the theme of this month, with women's health and youth health services that are available and can be accessed in and through our pharmacies, including the getting advice from other healthcare professionals and referring where it is necessary. And yourself as a pharmacist, you know that that is beyond your scope of practice to refer to the relevant healthcare professional even through this time. And with that, colleagues, thank you very much.
Thank you very much, Zianda and Mr. Nganyane. Thank you very much for the presentation. And I see we have a lot of questions from our attendees, and hopefully just not to keep you for hours here, because we need to finish by 7. Maybe let's try and keep the answers as short as possible. Maybe then we'll be able to cater to all the questions. But before I start taking on the questions, I would like to ask Mr. Johannes Mangane, who is my partner, and Pindile Mnyanga, to just comment on the presentation if they can. I know they are also struggling with a load shedding. Johannes and Pindile, are you able to say something? Okay, then I'll move on. Dr. Mawela, any comment on the presentation, or do you have any question? Let me start with you.
No, actually, just to appreciate, the presentation. I think it has covered most of the pertinent things. Obviously, it's a pharmacy a webinar series, but I think the majority of the issues are introduced by ourselves, health professionals or the prescribers. Yeah, so I think let's go through the questions and then I will engage as well as we continue. But a well prepared talk and targeting specific things that are very important. And we should not miss as well that this month, in addition to celebrating our pharmacists, we also celebrate International Patient Safety Day. And it's quite important to note that the theme for this year is around medicine safety. And medicine safety is strongly linked to how we prescribe. Sometimes you put a comma where you're not supposed to put it. Sometimes you put an extra zero. And we have also seen that medicines that sound alike or the names are very close, we can make mistakes. So I think it's a very relevant topic for either way. So I think let's go through the questions and then we take it from there. Thanks.
Thank you, Dr. Mawela. Welcome to the pharmacy profession. I think we're just going to anoint you as one of our pharmacists. I'll start with the first question to Mr. Dlala, Ms. Zianda, and Mr. Nkanyane. The first question is, what is the difference between a licensed prescriber and an authorized prescriber?
Thank you, Mary. I think maybe let me start with the licensed dispenser. Licensed dispenser is somebody who's been issued a license to dispense. In this particular ones, we refer mainly to doctors or nurses, or sometimes even the, what do I call them? The homeopath that would have done a dispensing course. After having completed and been declared competent, then they can apply to the DG to be issued with a license to dispense. And such licensed dispensers can only dispense that which they've prescribed. They are not allowed to dispense all prescription. So the limitation is they must dispense their own. So here we are talking about dispensing doctors and dispensing nurses. The authorized prescriber is as defined in terms of Section 22A17 of the Medicines Act and also 22A14B, where it specifies that a nurse or a person registered under Health Professions Act may be authorized to prescribe. Obviously, they need to obtain the necessary competencies, and the said regulator would have to specify what conditions they may be able to prescribe. And as such, once done, they have to work together with SAPRA, and then such people would then be authorized to prescribe a list of medicines and then for particular conditions. And that's where we refer a pharmacist or a healthcare professional to the schedule in terms of the Medicines Act. That's where the difference is.
Okay, thank you very much. Colleagues, please note that we have a Q&A tab at the bottom there. Please use that tab to post your questions, because it will be difficult for me to move around the two tabs on charts and the Q&A to look at the questions. Just use the Q&A tab, then we'll be able to follow with the questions and answers. Thank you very much. Second question is, what about emailed and WhatsApp prescriptions? How do we manage them, and how do we guarantee that the same prescription was not sent to other pharmacies? And
Thank you.
Zianda, yes.
Thank you, Ref. I hoped Mr. Nkanyane would be here to say, to answer this one, but that's fine, that the email that comes to the pharmacy must be from the prescriber, not from the patient. And I'm linking this together with another question that's just down, I've just caught my eye from Mr. Mafarafar, that So such email may not be coming from the patient to say, my doctor gave me this. If it's via electronic means, it must be from the prescriber to the allocated pharmacy. In that way, it minimizes, and we are hoping that the prescribers haven't sent it to multiple pharmacies, they've just sent it to the one. And this is where the ECTA starts coming into play, where if it's an electronic or a digital prescription, the encryption of that signature and the electronic signature, those limitations are followed through. That's number one. Number two, should it be that it is an email prescription and it is a prescriber, because remember, as a pharmacist, you're supposed to verify that the prescriber, you know them. It must be followed with the original prescription within 7 days. We did touch on it. Right, so that is the fax and the email transmitted prescription. So if you're going to then be dispensing it as a pharmacist, ensure that you receive the original one. Otherwise, if it's an electronic one, it must have the electronic signature encrypted in compliance with the ECTA.
Okay, thank you. The next question is,
thank you, Zee.
What about poorly written prescriptions? Who is liable and what can we do to enforce eligibility? I know Mr. Nkanyane mentioned that doctors need to write in slow motion, but is there a better way of phrasing the response in terms of the poorly written prescriptions? And please try and debunk the myth that we are taught this at school as pharmacists, because it's not true. We can't read the handwriting. We're not taught that. Can you try and answer that in a simple and concise answer? Thank you.
Mr. Nkanyane?
I think it's
Thank you, Chair. Thank you. Can you hear me?
Yes, we can hear you.
Okay, thank you, Chair. So the question of eligibility, it is also answered by the regulation in section 2A5B of the Medicines and Related Substances Act, in terms to say it goes back to authentication of the prescription. But it might be a challenge where you have a big line just to call the doctor and try to authenticate the prescription. So it's a matter of workload where you are working, whether you have more patients on the line and you have a frustrated patient who wants to get the medication and move away from the pharmacy. But we advise our colleagues, the pharmacists, to be more relaxed and try to contact the prescriber. In most instances, the prescriber and the pharmacist, they know each other. So in most cases, it's more simpler to contact each other because they have that type of a relationship where if they cannot see something, then they can contact each other. So we advise our pharmacists to contact the authorized prescriber to just authenticate the prescription. Maybe the other issue was in terms of the WhatsApp. So I don't know, because the ECTA Act will define your email, and I've tried to grapple with this concept of data message that I've seen on the ECTA Act. Maybe colleagues can go and read what is meant by a data message, whether a data message will also include a WhatsApp, a prescription that will be sent from the authorized prescriber by WhatsApp to the pharmacy. So I'm not clear. I will not want to mislead colleagues. Thank you.
Thank you very much.
All right.
We take a question from Ama, our Ghanaian sister, I think.
Okay, cool. And Ruben as well, thanks.
And Ruben Mtomben. Colleagues, please note that already we have 52 questions in line. I don't think we'll be able to cover all of them. So try keep your questions very short and the responses from Pharmacy Council as short as possible. 52 questions is a lot in 15 minutes. Thank you very much. Ama, please take over.
Good evening, and yes, I am Ghanaian. I just wanted clarification on the term legible. that is stated in the Pharmacy Act? Is it legible by the prescriber standards, legible by the pharmacist standards, legible by the patient standards? Because that's the challenge we face as pharmacists. You get a script and you can't read it. You call the prescriber and they tell you, but I can read it, therefore it's legible. What are you supposed to do in instances like that? When the Act says it's legible, who is actually supposed to be able to read the prescription? Is it just the pharmacist and the prescriber, or does that also include the patient? Does that include any healthcare worker that interacts with that patient? Thank you.
Thank you, Amma. Ruben, can you pose your question as well? Ruben Mtombeni.
You may unmute, Ruben. Proceed with the first question, thanks.
Okay.
Hello?
Yes, Ruben.
Okay, mine is with regard to the prescriptions that are telephonic, or the prescription that you find that you have to fix it. You phone the doctor and then you have to correct it. When it comes to it being accompanied by the original, I know you have to speak to the prescriber that you know, but sometimes because of distance, I have seen in real practice that normally the original prescriptions don't come. So in a case like that, it's either because maybe the prescriber is far, but you do know the prescriber, maybe the prescriber is in Polokwane. How do we deal with it in order to get the original prescription? Thank you.
Thank you very much. Z, can you answer?
I think Mr. Nganyane is better suited for that one. Thank you.
Okay, Mr. Nganyane.
Thank you, Chair. I think the eligibility in terms of the patients, some of the patients are not literate, so it's not all patients that go to a doctor who are literate, so they will not even know what is written in the prescription. They will be just be told by the doctor. So in terms of eligibility, if the doctor says he can see, I think I once represented a client and I did a plea settlement, but even my client could not see what I've written there because I used my hand and I have a bad hand writing. So it always good to have that working relationship. I know that it is very frustrating, like what Mr. Mtombeni has raised, to say you have a doctor that is in Polokwane and then the prescription is not coming. And when we do an audit in terms of the inspection, you will say that we do have a prescription, but it was not forwarded to us. I will because you have an established relationship, Mr. Mtombeni, with the doctor. For sure, you have means of doing this with the doctor. So we always encourage pharmacists to get the original prescription for filing purposes and to avoid over dispensing to one patient, because they might come with different prescription from different doctors. But if you have the prescription.
So what was the answer to Amma regarding who's
So the eligibility is it's the doctor. You must go back to the doctor, because if you say you don't see it as a pharmacist, that means you can't see. So the doctor must clarify to say what type of medication he has prescribed there. Thank you.
All right, thank you.
No, if maybe just to add on that,
okay.
you know, when you go to exclusive books and all this bookshop, there's always something called for the dummies. Né? What I'm saying is any prescription that's legible, even a person who's not a healthcare professional should be able to read it. You don't need to be a healthcare professional to read a prescription. So legibility means exactly that. It must be, any person must be able to read what is written.
Okay, thank you. So what about self-prescriptions? Are they legal? Also, another question is, are pharmacists covered by law when members of the public consult them for over-the-counter meds, even before they are being seen by a doctor? So those are just two questions. Thank you.
Okay. What was the first one, Refi? I'm so sorry. I missed. I caught the last one.
Self-prescriptions, are they legal?
Well, when I have a headache, I take a paracetamol, maybe, so I've self-prescribed. However, it is discouraged that you prescribe for self. We are health professionals. We know that that headache that you just keep on taking the grandpa for may not be a headache. There might be other causes for it. And that is the reason why you have to consult somebody else. And so in the code of conduct, it becomes clear for us that, yes, as I said, you can be taking a paracetamol because you've got a headache now. However, even the medicine itself says, if you are not assisted by this within 10 days, go and consult. So this is why then it is discouraged that you self-prescribe, because you are going to miss something with yourself, because I know my body. Someone once said that I do know my body, how it acts like. However, I don't think the act discourages that very much. So I'm hoping I answered that. And the second one, Refi?
The second one is, a pharmacist covered by law when members of the public consult them for over-the-counter meds, even before they are being seen by a doctor?
It is within the scope of practice of a pharmacist, according to the Medicines Act, to prescribe, and this is called pharmacist-initiated therapy, not over-the-counter. And that is one of the reasons why we are, as registered persons with the Pharmacy Council, as like all other healthcare professionals, supposed to have professional indemnity to be covered in such circumstances. Because a patient may come, we know that they would walk into the pharmacy to, probably the pharmacist who will say, I think in this case, go and see the doctor. Or the pharmacist may say, no, I think I've got Bactroben, you may use this on this that I see on your skin. So professional indemnity, that's what it's there for, to be covered for such instances of pharmacy-initiated therapy.
Okay, thank you very much. So I know this was mentioned during the presentations, but if you can just summarize this, what are the limitations regarding the nurse prescriptions? I see one of the pharmacist assistant present here also asked, what can they do when they are forced to dispense nurse prescriptions from nurses who do not have the Section 56 permits? So I think they are kind of linked, but the question mainly is, what are the limitations regarding nurses' prescriptions? Thank you.
Thank you. I'll ask Mr. Tlala to add after I finish. The Section 56.6 designation says that, and it also comes from the minister's desk, it is nurses in the public sector that are covered by this designation, or those that have been given authorization in terms of 56.6D, that the DG, in consultation with the South African Pharmacy Council, has given designation to a health establishment to offer health services to a community. That becomes the first limitation on which nurse may prescribe. Remember, the nurses, according to their scope of practice, may keep, supply, administer their medicine. But 56 then says the nurse may prescribe. Now, for where at the point where an assistant particularly feels that they are and is being forced to dispense such a prescription where there is no designation, I would want to ask, is that in the public sector? Because the nurses that are in the clinic are covered by the 56.6 designation, which is why you are there in the clinic to offer that service, to issue the patient the medicine. But if it is being done such that you miss your scope of practice, your supervising pharmacist, please report that, because that needs to be reported. You may not act outside of your scope, because should anything happen, the first question that you get asked, not even by the Pharmacy Council, let's say a patient sues and goes to court, will be, did you act within your scope of practice?
Yeah.
Thank you.
Mr. Tlala, do you want to add on?
Not at this stage.
Okay, thank you. The next question is about PCDT pharmacists. Are they authorized, as I understand that they are authorized prescribers, then does it mean that by law, they are not allowed to own a pharmacy? Thank you, that's a question.
A pharmacist can own a pharmacy and be a PCDT pharmacist. Remember, your PCDT, it's in terms of Section 22A15 of the Medicines Act, where then you are given a permit to prescribe for a list of medicines and a list of conditions. Therefore, you can have a pharmacy and do such. We normally would advise that there is segregation of duties, that whoever prescribed the another pharmacist must look at the prescription. And going back to that whole issue of self-medication, I think in terms of even governance generally, whether it's clinical governance, we want objectivity and not subjectivity, that there is another person and second pair of eyes looking at that particular prescription. So that is why from our side, we will always discourage any these self-medication issues, particularly when it comes to Schedule 3, 4, 5. Even Schedule 1 and 2, a pharmacist, by the way, may refuse to issue such medicine if they are of the opinion that there is an abuse.
Okay, thank you. Dr. Mawela, I think we forgot to put a footnote, to add a footnote or a disclaimer that whoever is attending this webinar should also bring along their Pharmacy Act, Medicine Substances Act, and the Nursing Act, because they are busy throwing us with Section 56, Section 22. Yeah, no, it's a lesson today. Anyway, the next question is, with repeat prescriptions, who should keep the original prescription when it's collected in multiple pharmacies? That's the one question. The second question is, there's a latest gazette on clinical associates, which attaches their independence of practice to the number of service in practice. This question is from one of my bosses in Gauteng, so please try and answer it correctly. So this question is the latest gazette on clinical associates, which attaches their independence of practice to the number of service in practice. Can you please clarify that gazette? But the first question is, with the repeat prescriptions, who should keep the original one when it is collected in multiple pharmacies? Thank you.
Thank you. I'll answer this.
Okay, let me deal with the first one. It is the pharmacy that does the last repeat that must keep the original. Remember, the prescription belongs to the patient, and the patient is free to take the prescription where it would be dispensed. But we always say at all times, as and when that prescription is being dispensed, please attach the trailer label so that we can track how long this prescription has been there and who's already done it. But it's the last pharmacy that does the dispensing that would keep that. In terms of the clinical associate, we would rather not want to go deeper into it. We would have to converse with the Health Profession Council as to the changes, because the last ones we had was that they had to work closely with a doctor. We are aware that there was a mood for independence of clinical associate. So firstly, let me say from our side, we're not aware of the latest documentation, but we're happy to take it up with Health Profession Council and come back to you and give you a written answer.
Thank you very much. Dr. Mawela, so you'll advise if I should continue?
Yes, continue. But what I wanted to check is around the dispensing license. Are all registered health workers, as per the different acts, allowed to do the course with an aim to get a license? For example, clinical associates. Yeah, basically maybe it's around the clinical associates. I don't know if that is linked to the question you're responding to.
At this stage, Dr. Mawela, I'm not aware that the clinical associates would be given a dispensing license.
Okay.
And for that matter, I would say for now, no, we would not be supporting such a license application. But safe to say, let's go back to the latest documentation, see, but it would be very interesting to see, because in order to get that dispensing license, it is meant for somebody who owns their own practice and to be able to dispense as such. And remember, it is also intended for a place where there's no pharmacist. So it might be very problematic that we just give the clinical associate the dispensing license.
All right. No, I think it's clear. Thanks.
Thank you. I think
Maybe Fifi. We see now we're in a formal meeting. I can't say Fifi. Colleagues, let's just extend the meeting until 5 past. Maybe Refilia, if you can just scroll through, take 2 key questions, and then let's have closing remarks. We will send the questions to our colleagues, and we can see if there can be some form of document with replies, and then we see if we can share it. Thanks.
Okay, thank you. My ESCOM is back with me now, so I can see clearly. So there's a question, is there anything if one professional, example, an optometrist writes an eye prescription med, but a medical doctor signs the prescription underneath the prescription before sending the patient with the prescription for dispensing by the pharmacist in the hospital setting? I'm not sure if it's supposed to be, is there anything wrong with that or illegal when one professional, an optometrist, writes a prescription, but a medical doctor signs? I think this is similar to prescriptions by clinical associates. And I'm not sure if you can take this question.
No, I will take it. Thank you.
Okay.
There is nothing wrong with the co-signing, but I must just highlight to the colleagues that remember the schedules. And you saw when I talked about the practitioner, that the optometrist was there. There is medicine optometrist may prescribe, unless the optometrist is wanting to prescribe something that's outside of their scope, then you would need the medical practitioner to co-sign. However, if the optometrist is signing a medicine that is within their scope and is listed in the schedules as published by SAPRA in the Medicines Act, then the optometrist may prescribe such medicine within the scope. It's very important, this issue of the scope, and that's how these schedules have been put to say, this is your scope of practice, you're an optometrist, you're a podiatrist, this is what you can prescribe, and it limits to that.
Thank you. Also, another question from my boss is, if Pharmacy Council can address the issue of practitioners, how many of them have schedules now, and how many are authorized prescribers, and which ones are those? That's a very mouthful. It's a mouthful question, that one. Mr. Tala, Mr. Nkanyane?
I think next time I'll bring the CEO of SAPRA.
Okay.
Yes.
So that we don't answer on their behalf. But just colleagues, it's important that you read the Medicines Act, because that's where all the things are updated. And if there are new authorized prescribers, you'd find in there.
Okay.
I actually thought you would be encouraging all of us to at least do the dispensing course, because it's based on the different elements of the act. It's just that people generally do it for the license. But when you look at the program itself and what is covered, it probably covers even issues of legalities of prescription, who's authorized or not. It could have been a program that is sort of, mandatory for health professionals who are handling medicines to at least do, whether you need a license or not. Yeah.
Okay, can I just take another question on telemedicine? How does a client get a prescription since consultation is done virtually or telephonically? And it also goes with a question that says, what is recommended? What is the recommended way of signing prescriptions for online consultations?
Yeah, I think that was covered. But let's get the final response. But I think there's now a whole lot of technology around, a proper way of digitally signing documents. And I think we might need to bring some of those kinds of providers so that they can share, what's going on. Because the issue of copying a signature, like writing it, taking a picture, and then putting it on a prescription, it's quite common. And unfortunately, that is illegal. I'm speaking because I'm transformed by the presentation. But please confirm what I'm saying is correct.
You're correct, Dr. Mawan.
I think yeah, continue, Dr.
Last week, I know the colleagues went to Netcare. as Netcare is rolling out the e-prescribing across its platforms. And that's where you would know the requirement in terms of this, that electronic act, what's specific. And that's why from our side, we emphasize, if you type it, print it and hand sign it, do not copy a signature and like you use your cell phone and then plug it there. It doesn't comply with the act.
Yeah. Okay, I'm even going to take the last question because I see most of the questions there are more related to the nurses' prescriptions. I think we have a challenge there, Mr. Tlala, Zianda, and Mr. Nkanyane, regarding the nurses' prescriptions, and there's lots of questions on that one. So I can't go through all of them because it's a lot of them. It's something maybe that we'll need to have another session again, maybe with Pharmacist Council, and maybe that we can maybe focus on that because we do have registered nurses in attendance as well. So
No,
I
that's
think it's a challenge for us on that one. There's one that I saw, but now I can't, because it's a lot of questions, but I can't find it now, but it's okay. I'm sorry if I missed your question, but yeah, thank you very much to Pharmacy Council, Ms. Yanda Mfuku. She's very strict, this lady, Dr. Mawela, and Mr. Nkanyane and Mr. Vincent Lala. Thank you for taking time to share your time with us and share the information with us. We're grateful, and hopefully we'll be able to go back and implement, and we'll be able to convert some of the doctors to improve their handwritings, and we'll be able to take care of our patients and look and assess the validity and authenticity of our prescriptions. Thank you very much, Dr. Mawela, for the opportunity again to host the pharmacy education webinar. We are grateful for this platform. I see today where a lot of pharmacists, I saw my colleagues from the Northern Cape, from KZN, from Limpopo. It's quite reassuring that as pharmacists, we are willing to do the right things and and show concern for our patients. Thank you to my colleagues, my partners, Pindile and Johannes from Engineers Pharmacy, a chemist for supporting me, and Dr. Mawela in this platform. But colleagues, for all of you who have attended today, thank you very much for your participation. I'm sorry that we couldn't answer all your questions, but we're grateful that you were here and hopefully that you've benefited. Dr. Mawela, over to you. Thank you very much.
No, I don't want to close this one. I want to give it to Mr. Tlala just to say a key message about to the pharmacist for Pharmacy Month, and then we close it. Mr. Tlala, you may close it for us with that key message. Thank you.
Thank you, Dr. Mawela. And thank you, colleagues, for also taking time to attend this session. We do not take this work lightly. I think it's a privilege for us to speak to yourself, as we know that you are the people on the ground faced with the patients and having to work with other healthcare professionals. So from our side, we indeed grateful for the work that you do, and we are at your service. If you do require us to come back, we will be happy to come through. And to all pharmacists, we encourage you to participate in the Pharmacy Month. As all of you would know that in the country, we have a problem of teenage pregnancies. And also during the COVID-19, we had a problem with some of the immunization not being covered. That is why the focus from both the Department of Health, Pharmacy Council, and the Professional Association, we have looked at the issue of the women and youth to say, let's make sure that we give attention to our women. And for pharmacists, you would note that the Pharmacy Council has approved the new qualification for supplementary training for family planning. So please do, once we have done the accreditation of the various providers, we would encourage you to do it as a part of supplementary training. We've also approved the qualification of short course on immunization. So for those of you who have not done the immunization course, we would also appreciate. And I'm saying this because that is intended to deal with mother and child, or women and youth in this instance. So we would encourage yourself to do those short courses so that then you have this supplementary training and are able to assist the mothers and children who would approach your pharmacy. And thank you very much for the hard work that you guys are doing. And also we want to also say from ourselves with regard to the COVID-19 vaccination, we have seen that the pharmacy professionals were one of the big group that came to the party to vaccinate the communities where you are functioning. And as such, I think as a country, we've been able to do well because of your involvement. So we are grateful for that, to say, respond in terms of disaster. And that's why we expect pharmacy to be in the forefront. And thank you. In preparation also for the NHI, we are rolling all this number of programs so that at the time NHI is in full swing, pharmacy can work closely with all other healthcare professionals to advance the healthcare services in the country. Thank you, Ndata